Hey Cam followers, a little bit of a different time this week. It's 6:30. I have the amazing Dr. James Hunt with me again. And today we're going to talk about structuring a chronic pain consultation. And you're probably thinking to yourself, this has got nothing to do with me, but it has, because you as the owner are guiding the consultation as much as the vet. So one of the things that we hear a lot on Cam is owners feeling disgruntled. They haven't seen the same vet. They don't feel they've got the service that they wished for. And what is the truth is that you can also create these consultations by being part of the process. If you understand the process, then you're going to get more out of your consultations. Hopefully, Dr. James agrees with me.
Yeah, I do. Yeah.
So,
they're a conversation. So yeah, it takes two.
It definitely takes two. So James is just getting over COVID, so be kind to him because he's feeling a little bit broken. And I feel really bad that I've dragged him out of his corpse bed to do this. So be kind and say thank you. But the reason I've asked James is not only is he a referral veterinarian, so he works with anesthesia and analgesia. So he worked at Caves, isn't it?
Yeah, I'm clinical anaesthetist. Yeah,
clinical anaesthetist. He also runs chronic pain clinics in a referral setting, but he's also stepping into doing his own chronic pain consults. And therefore, it's a really interesting topic for me and him because obviously I'm fascinated about solving the chronic pain problem. And I run chronic pain consults where I'm based down in Bude. So we're actually very close. So we wanted to talk about what could we do in a consultation? How can we get the most out of that limited time? What resources are available to you guys? How can both parties play a role in maximizing that consultation time? Hopefully that we can have a ripple effect and disseminate this into first opinion practice around the globe.
Yeah, and take ideas from first opinion vets as well.
Exactly. So I'm a first opinion practitioner, which means that I'm potentially more limited with time. I have people come to me that aren't engaged in that they haven't driven to a referral centre. They're not planning to go on a referral journey. So they're pretty fresh. They're not expecting what I'm going to say. They may be still in the belief that a pill will answer everything. So we've got different angles of the same problem.
Yeah.
So first of all, James, tell them a bit about yourself so that people have faith in everything you say.
So I was lucky enough to go to Royal Vet College and graduated from there in 1998. And always had a strong interest in pain management and analgesics, so the painkillers that we use to manage pain in animals. And so then studied for some more qualifications in anesthesia and pain management. And then that led on to doing a master's degree and PhD, all looking at pain in dogs and cats and kind of working in practice alongside doing that. And now, like we were saying, I just work in referral centre. So yeah, it's been, I've seen a few different aspects to things.
Yeah, definitely. So what we're going to do is I've got a little bit of an agenda. And first on our agenda was discussing how difficult consultation environment is with regards to what we're trying to achieve. And I've listed from A to J, and I'm just going to, and we can discuss them. So in that consultation, for me, it's going to be 15 minutes, sometimes even 10. I even worked in a practice that gave me 7 minutes.
Yeah.
Generally, that's hello, come, see you later, bye.
Yeah.
Now, how long do you have in a more referral setting?
Yeah, so definitely my experience in primary care was similar. So somewhere between 5 and 15 minutes. Now my consultations last for between 60 and 90 minutes.
Very lucky. Very lucky. Now, something I will add is that there are chronic pain practitioners out there, and I spent a little bit of time having a mobile service, and that did allow me as a primary care veterinarian to have a bit more time, because we do need to think about the practicalities that vet centres, veterinary practices, have overheads. And when you're occupying a room for an hour and a half, and you've got all of the costs associated, and you're still trying to put it out for 45 quid, it just ain't possible.
Yeah.
So there are now a developing field of chronic pain practitioners that offer more of a mobile service. So there you go. Okay, so next thing, the list of what we're trying to achieve. In that 15-minute up to 90 minutes, what is the problem? Taking history, collecting data, reviewing the clinical history from previous up to years in the distance of injuries that were occurred when the dog was 2 and it's now 10. Mm-hmm. Examination, which is a pain exam, myofascial exam, clinical exam, neuro exam, orthopedic exam. Coming up with a suitable treatment plan that the owner understands and buys into. Further management requirements regarding lifestyle, exercise, and weight control. Discussing how to give the meds safely, when to be re-seen, and potentially more. That was A to J. When you actually write it down, what's your
struggle?
Always going to be a struggle, isn't it?
Yeah, and I think, you know, what you have to do in a primary consultation is to prioritize. So we're going to attack the most important signs, and we're going to attack the I guess the interventions that are going to have the most impact straight away.
Yeah, no, I agree.
Only way that we can get it into that kind of time frame.
And I think I also definitely always have a conversation of it might be just a minute. This is me unpeeling an onion, guys. Do not expect me to identify all the causes of concern, create you the perfect treatment plan that's going to last the next 10 years, because it ain't going to happen. But what we're going to do is slowly unpick, unwind, and each occasion or each opportunity I have contact with you, be it by email, phone, by one of the online resources, we'll tackle something else.
Yeah.
But I do like people to know how much there is that we can do to influence, so that they don't go away thinking that there's a unimodal approach. Do you do the same?
Yes, yeah, very much. And I've got the luxury of having a lot more time to explain in person rather than relying on, kind of online information or handouts and things like that, which are really, really, really helpful if you're under time pressure. But I can discuss them and then use those as well. So I get the double impact of kind of owner education in those situations.
Yeah, and I was one of the reasons that we're doing this live is to also dabble in the water. So please do give comments about what you've experienced and what's worked with your understanding, managing your expectations, guiding your treatment plan, because I've just started at a new practice down in Bude and I'm loving it. And I'm trying to create the perfect chronic pain consult and first opinion practice. What is possible within the boundaries of 15 minutes in a busy practice where you've got a dog in heart failure, a bitch whelping, a vaccination, all around this beautiful 15 minutes opportunity to influence a dog for the rest of its life. So what I've been doing recently is trying to encourage my owners to use some of the CAM resources. So we have an essentials course for owners, which is a presentation, so they understand all of these elements. We have a 10 email series, so an email every day for 10 days. And I try and have them on that before they see me. And I really encourage them to go into CAM because I'm biased. I love it because we created it. And what I am definitely finding are my owners are coming with better expectations, a greater understanding that this isn't going to be a quick fix. They start developing their own questions related to their dog rather than generalist questions. Yeah. So yeah, I'm kind of doing the same, but I'm trying to preempt the consultation using resources that are available. It works some of the times, but the owner has to be engaged. They have to already have identified it's a problem. So when you have situations where you've got an owner come in for a vaccine and you're like, you've got a big problem going on here, it doesn't work in those situations. So the conversation is very different. And what I've started to do now is realize that I cannot do everything. So I will say to them, this is what I see. These are the things I've identified in your dog. This is what I'm worried about. And I would love you to come back when we can have a little bit more of a calmer approach, because we've already lost 10 minutes dealing with your vaccine and your clinical exam. But these things need more time. Is that the sort of thing that you used to do?
Yes. Yeah, I think you do need to be in a slightly less rushed position to be able to go through everything in a kind of methodical way. And it's a big deal because you're potentially talking about changing lifestyle, changing exercise, changing diets. There's quite a lot to actually take in. And if it's tagged into, 2 minutes at the end of an annual booster when you've just been wrestling, trying to do the kennel cough up the nose and that kind of thing, nobody's in a good place to to have that conversation then.
No.
So yeah, definitely if you can schedule an appointment, if clinics have quieter times, then it might be they are able to facilitate doing these types of consultations then as well.
Yeah, definitely. So tell us what you think about this, guys, because this is more of this isn't a lecture. This is us problem solving together. And this is me and James talking about what we're both doing. He's branching more into his mobile service. I'm developing more of a chronic pain service, First Opinion. We're both having obstacles. We're both passionate about what we do. And we both think that we're onto right tracks. But, give us your feedback. How would you, as a client, you've just brought your dog in for an annual health check, and the vet says, look, I've identified a problem, but I am not going to be able to do this justice with the limited time that I have available. So I would like you to come back and we can then tackle this together in a better time scale. I can give you some preceding information, which is my approach. How do you feel about it? Let me know. So, each consultation is a similar approach as the clinical picture is likely changing. Oh, right. So this is the other thing that I wanted to kind of tackle. I had a couple of owners feel that it felt very repetitive. And I was a bit taken aback at that, in that I take a lot of pride in trying to go through everything. And I did have somebody at one point kind of go, haven't we been here before? And I was like, yeah, well, the thing is, a lot of people take 2 or 3 times listening to something before they act on it. And also your dog's clinical condition is changing, because 4 weeks ago we put on a non-steroidal, and what was very evident then has changed. So we've lifted a layer of the onion of pain, and we're now getting down to maybe the primary sources. So I have to run through my procedure again. And that's been really evident to me a lot recently. I had a really good one today, actually. Oh, you'll love this. This dog was believed to have potentially cruciate, and it was a sciatic pathway. So that's a classic, isn't it? Holding to do a cruciate and you're actually pressing on the sciatic. So he's just been on a course of gabapentin for 4 weeks. Pressing down, nothing. Yeah, no lameness. But this is what I mean, that the preceding vet had done everything as planned, had started to speculate that the cruciate was tweaking, there was discomfort associated, but only with time have we unraveled the onion and gone, wait a minute, that's not actually happening. You've seen cases like that as well?
Yeah, exactly. So it can be incredibly difficult to try and isolate a source of pain in a non-verbal animal. In many situations, whenever you're manipulating around the area, you could be putting pressure, on the joint, so on the stifle in a cruciate case, but the way that, you know, the tests that you're using to examine the stifle, you may also be putting pressure on the sciatic pathway. And so, you know, if you get a response, you need to try and be confident that it's, you know, from either the joint or a muscle or a nerve or this kind of thing. And it can be very difficult to be 100% sure of that. And I think the more cases I see, the more I realize that actually an important part of seeing these cases is to keep questioning yourself.
Yes.
And so the repeating the examination is really important.
Yes. And it's really sad when an owner might say, look, you've done this before, come on, let's move on. And you're like, no, you don't realize I am being super blinking thorough. I've got another example today. Oh my God, a day of many things. So we've had a young Labrador, no more than around about 6-7 months. And one clinician could identify that it was a forelimb lameness, but really couldn't localize where the pain was. And then another clinician with the practice saw after a period of rest and a short course of non-steroidals and really started to think it was elbow, but you know, still very difficult. Wriggly puppy, really happy to see you, not centrally sensitized. So really happy to throw around on its back, on its front, on its back. So we did x-rays. We didn't find anything associated with elbow. I always say shelbow, so I always look at the shoulder as well. Didn't see anything with the shoulder. Had to extend the period of rest. Course and anti-inflammatories, dog doing really, really well. And then recently, sudden deterioration again. The owner associated it with the puppy being exuberant in the garden. And today, pain, distal radius, panosteoitis. Now think about this, guys. To manipulate the limb into any kind of carpal flexion, extension, elbow, you're going to hold the radius. You're going to hold the radius. So all of these hints of pain maybe in the elbow was more than likely compression of the radius, but there was no other giveaway. And that's another reason that having the opportunity to do a full clinical exam and appreciating that your vet is doing that is really important. Can I let Ruby in? Can you hear this dog?
I think you better.
Sorry, it's a friend's dog who smells of fox poo. Come on, in you come. You come in. Okay. Sorry, guys. Come on then, up. Okay, got two. Ruby, come on. Oh, yeah, you'll see her in a bit. Luna and Ruby. Okay, so that's another thing. And that's why when you're looking at these chronic pain clinics, having repeated time and having a repeated process so you don't miss things is really important, isn't it?
Yeah, and it definitely changes. You know, it's very rare that you have a case that only has one source of pain. So they might have joint pain, they might have associated muscle pain, they may even have a nerve pain, and they may have central sensitization. And each time you see these cases, you want to try and assess what proportion of the overall pain picture is coming from these different aspects, because they may have different treatments.
I agree, and they're in the slides in a minute. I made slides. And that's really true, because medications work on different processes. And as you say, you might have neuropathic pain, you might have nociceptive pain, you might have myofascial pain, and they respond very differently. So what's the take home from this is us as a clinician and us as owners trying to maximize the time together. So we've had some lovely points about, I try to book an end of day appointment. Brilliant. Try and book an end of consult session. So it might be just before lunch. So if you roll over, that's okay. Be open to the ideas of asking for a double appointment. I can't promise that your clinic might not charge you more, but you could always phone up and say, look, I know that this is going to be lengthy. What's the opportunity of more time? And your clinic might actually go, that's fine. Yeah, absolutely. We'll book you for a double, because they would rather that than your vet run behind and have people stockpiling in the waiting room. So think about how you can create more time. Think about how you can take some of that information. I'm just going to run through that list. What is the problem? Okay. amount of times, did I tell you about my chocolate teapot moment recently?
Yeah.
I actually did tell someone.
Go on.
Their husband was a chocolate teapot. So this guy turns up with a dog, and I'm like, so what's the problem? He's like, I don't know. I was like, any clues? Nah. Can you tell me what's wrong with the dog? Nah. It's like, his wife's dog. It's like, okay, this is not helping me at all. Not a sausage of information to help me guide what I was going to do. And when the wife came to collect later that day, I was like, your husband is a chocolate teapot. So please make sure that you turn up with an idea of what the problem is. Please.
Yeah. If you're not able to turn, you know, some people may find it difficult to attend a consult in person. So have a conversation with the vet on the phone, or send in some written questions or a problem list.
Yeah.
Just give us an idea.
Yeah, no, absolutely. And if you've got a list, there's no harm in emailing it in, and reception can print it off. So we've got it before the consultation. That's not, you know, it's a good idea. Remember about the dog's history. So I've had cases where, you know, 3-6 appointments in, and eventually Annie goes, yeah, oh, do you know what? A year ago, he got clipped by a car. And you're like, okay, that's quite important. So think about the history. Have a kind of like, what have you seen previously? What have you tried previously? That's really important as well. The amount of times that I say to people, what was your response to this? I don't know. Okay, what about this medication? No. You know, this is not helping me. This is very hard. So have history, data collect, exactly like James was saying. Come in with a video, with photos, with a description of what you're seeing. There's a brilliant document that the lovely Compensatory will put up, suspicion of chronic pain document. Lynn will do it for us, and write down what behavioural changes, what postural changes, what physical changes. Make sure that your dog is calm. This is another thing that's quite drives you crazy. And they've just done laps of the waiting room in the car park, and they're really wound up, and they come into the consult room, and you're just like, I need to chill. I need to chill. Because whilst they're aroused and highly strung, we're not going to get much out of that examination. So a gentle walk, or staying in your car until you're called, keeping them calm, really good. Listen to the treatment plan and tell us if it's not possible. So I had a lady today who said, I know you said about paracetamol 3 times a day, but I work 12-hour shifts, so I haven't been giving it. And you're like, you could have told me. We could have thought about this. We could come up with a different plan. Further management ideas, which we're going to come into a bit. So lifestyle, exercise, weight control, all of these sorts of things. Nurse consultations. There are many clinics that offer this as a subsidiary service to support the vet, but also think about what CAM offers you. In that, we've talked about CAM Essentials, we've talked about the downloadable booklets, the email series. There are many ways that you can get a lot of background knowledge before you go to the vet, and you could say to them, I now understand about lifestyle. I'm pretty cool about weight, and I've got a plan. I've modified exercise. Can we now talk about the drugs? Can we talk about the therapies? Can we talk about the surgeries, the diagnostics? So do think about things that you can do there as well. Have I missed things?
No, I think that's sounding good. I was just scanning through the...
Yeah, do you want a tangent quickly? We've got a little question here. I'll do this one quickly. So, Carol, there are a number of Facebook Lives that we've done recently with a nutritionist, Cecilia Villaverde. The nutritionist that we use is double board certified. So she is as high as you can get in both America and in Europe, which is really unheard of. She's also got a PhD in nutrition, and she doesn't work for any food companies. She is an independent consultant. And at present, the literature to support the idea of grains being inflammatory to such a negative degree that we would rather not have them in the diet because they offer no other benefit is just not there. So the idea that grains are so detrimental is not supported by evidence currently. So what I would say is go and watch one of those Facebook Lives. There's many more available on the CAM platform. We've also got a book about nutrition, a little booklet, 44-page booklet. You can have a look at that. But the fear of dry food isn't substantiated whatsoever. And in honesty, I put dogs on kibble-based diets to get weight loss, really accurate, actioned weight loss, which I see way more benefit than I do dabbling around trying this, that, and the other. So I'm not against using dry food at all. What about you, James?
No, I would agree. I mean, there's certainly evidence that certain changes to diet can have positive impact on arthritis. So the omega-3 story, and then there's some more recent evidence about the eggshell membrane as well. So there are commercial diets designed to support joint health, which incorporate those kind of elements. And they also feature in lots of joint supplements as well. So there are things that we know help joints in the diet, but I agree. There's not enough evidence that a normal kibbled diet contributes to development of arthritis.
Yeah, I think what I definitely find is that people are trying to find a nicely defined solution, and it really isn't like that. And when you look at a case of an arthritic dog or a dog that's in the early stages of arthritis, there are so many variables to be considering. You almost have a little bit of a seesaw, juggling, moving things around. Okay, it's chaos in here. Never have two dogs in a room whilst you're trying to record. Next section is areas that are often overlooked that really are important in creating improved concordant treatment plans. Now, on my list, and we're still in 15 minutes, guys, 90 minutes. How am I going to get these things across to my clients? First off, I've got A to F. Identifying pain as observational markers. Turning it into an objective assessment form. Environmental and home adaptations, which is my big baby. I am so into that stuff. Understanding the actual disease process to manage expectations. Explanation of how to use drugs safely, because we know from your own writing that there are links with the adverse events being associated with people using these medications inappropriately, and the importance of routine monitoring. So that's all these things that I feel are routinely left out of a consultation because of time constraints and owners not really being interested and switching off and people being burnt out. Would you agree?
Yes. Definitely, if you're, if you know you've got a waiting room full of people, you're probably not then going to launch into all the ways in which you can manage the environment so that we're not increasing the risk of trip hazards or falls or anything like that, which is going to exacerbate an already inflamed joint. We're probably not going to delve into the natural progression and the waxing and waning of the disease, which happens over time. So they have good periods, they have bad periods, they have flare-ups. And it is helpful for people to anticipate those so that when it happens, they have a plan already in place, rather than suddenly the dog slipped, is become much, much more lame. And now, it's 9 o'clock on a Friday night. You've got to try and get somebody, to attend to the dog as an emergency.
Absolutely. We were looking at starting a breakthrough pain type kit, an acute flare kit, and having it in the CAM shop. So people that when they have an acute flare, so if you want to be really cool, guys, it's an acute and chronic disease. Is what people are now saying. That's the phrase. But yeah, I think it's really hard to try and have the opportunity to say to people, this will flare. and there are different reasons it will flare, and hopefully over time we will identify underlying causes that induce a flare. And this is what we're going to do when you have a flare, and it's going to be 7 to 10 days, maybe 14, feeling pretty like, this is hard work, and then we bounce back out the other side. Where do you fit that into the 15 minutes?
Yeah.
Tough. Really tough.
Definitely tough. And obviously once you've addressed an analgesic plan, so painkiller drugs, you've addressed a weight issue, then ideally we want to have a kind of ongoing physiotherapy or exercise plan which maintains muscle and helps to strengthen the muscles and ligaments around the joints, so that we do maybe have fewer or less of a risk of an acute flare.
No, totally agree. So as you can see, I'm hoping that we've had 50 odd people watching, and we're still roughly there. People aren't getting totally like, huh? There is so much to cover in these chronic pain clinics. Hopefully, in a bit, I'm going to put some slides on and just give you an idea of some of the resources that CAM's got available to help you, the client, go to your consultation and create structure. And if you're a veterinarian, a vet nurse, a rehab vet, a rehab tech, a physiotherapist, a hydrotherapist, you can also look at using them to structure your clinics. So actually, I might as well do it now, but it does mean I stop seeing your pretty face, James. So
I'll go off and cough in the corner.
Go and have a choke in the corner. Okay.
I think having access to like the CAM resources and things like that is really helpful, because the more an owner has an understanding of the disease and what's going on, like you say, they can ask more pertinent questions. They've maybe witnessed some of the flare-ups with their own patient, and they're in a position to then take on board much more of what the vet's saying. So yeah, I think as much education as possible on both sides of the table is really helpful. Hugely.
And to big up CAM and the CAM team, we've been going since 2016, and I think we've been doing these live since around about end of 2017, 2018. So on the CAM YouTube and through CAM Facebook, you will have access to 400 odd videos. There's so many now. Yeah. And it's really within your interest to have a scan through and just have them playing while you're cooking dinner, walking the dog, and start gathering information. So we haven't got the textbook way. Hopefully, after I've formulated a plan for the next 2 years, I will be doing exactly this interview again with James in a year to 2 years' time, and we will tell you exactly how to do it. But at present, I don't think that exists, does it? Every case is different.
They are, yeah.
So I just wanted to talk about that witch pain. So these are the 2 slides, and James, I'm going to probably leave you to just explain that. When people go, well, pain's pain, I'm just going to let you play with this so people understand when we talk about different pharmaceuticals and different approaches.
Yeah, pain's a tricky thing because we all know what it is, but I can't feel your pain and you can't feel mine. So it's always an individual experience. So osteoarthritis, which is the focus of our talk, is an inflammatory condition. So it's a sign of itis, an inflammation of the membrane and the tissues surrounding a synovial joint. So those joints that we have in between our bones. And inflammation anywhere in the body will produce molecules which sensitize the nerves to pain signals, and so when we've got inflammation in a joint, we feel increased pain associated with normal movement of the joint. It might be that it's swollen, it might be that it's hot, it might be that it's stiff. This is a chronic condition that's happened over time, so actually you can get quite a lot of thickening of the tissue and a reduction in the range of motion of the joint. But when it does move, it can be painful, or have a smaller pain-free range of motion. So that's what we would expect to find with a kind of single joint osteoarthritis is pain focused on that area, whether it's an elbow, whether it's a hip. We can identify that as the source of pain. Because our nervous systems are plastic, they can change over time. So that gives us an advantage in that we can adapt to our environment. But the negative consequence of that is that the nervous system can become hyper responsive to pain. So the more intense the pain and the longer it goes on, the more our nerve cells in the spinal cord are more likely to behave in a hyper excitable manner to pain signals, and that's what we start to call central sensitization. And then we have the pain not only in the affected area, in the affected joint, but we can also see increased pain signaling outside that area. So we get what's called a secondary hyperalgesia in the surrounding tissues or in distant tissues. We do so the change in behavior thing, I think, it might be a marker of central sensitization, but I think we can see a change in behavior associated with any kind of pain, but I think we're more likely to see changes in behavior associated with more severe pain. And because central sensitization tends to give us more severe pain because it's spread over a wider area, then we're more likely to see the behavioral changes. But I wouldn't rule out just a single joint arthritis giving us a behavioral change. That, if a small child knocks into the dog and they've got a sore elbow, the dog might snap.
Yeah.
And that could just be from a single joint osteoarthritis there. And
then we got those kind that might also be present.
Yeah. So neuropathic pain pertains to types of pain which are generated by what's called the somatosensory system. So the nerves that detect stimuli in the environment. Those can be difficult to establish because they won't always be present. As it says on the slide, sometimes they cause signs of spontaneous pain, so a sudden, turning around to look at an area or nibbling at an area, something like that. They can cause peculiar sensations, so they can cause pins and needles or burning. I actually have a neuropathic pain in my face. Yeah, like a trigeminal type thing, and it sometimes feels like there's something crawling in my ear.
Oh.
Yeah, so really strange sensations, just because the signaling in the nerve is slightly disrupted. And there might be a physical reason for that, but it might also just be a function of the nerve. So it can be associated with disc problems or radiculopathy, things like that in the spine, but it can be that you've got a misbehaving nerve. And then myofascial pain is somewhat nebulous at the moment, in that we weren't taught anything about it at college 20 years ago.
No.
But certainly it seems to be that the fascia and the muscle tissue can contribute to ongoing pain, and actually that can be as severe or more severe than the sort of predisposing problem. So if you think you've got a sore joint, and so you alter your gait and you alter the way you hold yourself, and then you end up with, often on the opposite side of the body, an overuse of the muscles and the soft tissues on that side of the body, and that can then, you can get a tight knot, which actually is really bothersome and really causes you a lot of problems. And those can persist even though you've treated the joint pain.
I was listening to a lecture, and the lady was saying in America, myofascial pain is believed to be the predominant source of, doctor complaints. And I often think about like my own back. I know that I haven't got a vertebral or a spinal related problem, but I have got back pain, and it's going to be muscular. It's going to be soft tissue because of posture, leaning over this blinking laptop. And it's persistent, and it burns, and sometimes it pulls, and sometimes it's sharp, and sometimes it throbs, and it can really get you down. Then there's also these two sly little buckets as well, which I've just kind of added, but I think we really don't know yet.
No, exactly. It's really difficult if an animal can't describe, where the pain is. I would say, oh, I've got this pain in my face and it goes up around here, and a doctor could draw on, see where it was. But for animals, is that pain because it's referred from a primary source, or is it painful because we've got a myofascial pain? And as you were saying, those symptoms with your back almost mimic a neuropathic pain. And I think these can be, you can sort of palpate a muscle, and an animal will whip round and as if they've really been stung suddenly. So yeah, I think the myofascial thing is underrated, or we evaluate it enough. And yeah, post-operative pain in people, chronic post-operative pain is very, very common. There's a little bit of work in animals looking at kind of post-amputation pain, and it does seem that there's likely to be a reasonable number that experience pain following an amputation. But for other surgeries, we don't really know. A stifle surgery or something, how many patients that we fix their cruciate then do have a post-operative pain? Lots of them do extremely well.
We just don't know because they don't verbalize, so it's so much harder to get that kind of data, isn't it?
Yeah, I mean, I think Duncan Lascelles' group looking at the kind of sensory testing, so they looked at thresholds for heat and for pressure in dogs, and those were reduced in dogs that had a cruciate problem, and then they normalized after the successful surgery. So probably having successful surgery kind of restores your nervous system to a naive state. But it may be that there are some animals that continue to have a sensitized nervous system.
Yeah, and I think all of us have experienced operations that the dog doesn't do so well, and you're just sitting there going, "What is it? Is it the mechanical structure that I've created from this surgical intervention, or is that actually really good? And my surgery is fine and it's stable, and that's not the source." And it's really, really hard to get to the bottom of that.
Yeah.
So I think I included those. These are from CAM lectures. So if you are interested in learning more, this is the sort of thing that you'll see in CAM Essentials, CAM Comprehensive, CAM Advocate, CAM Practice Training. But I just want people to realize, like, it's complex. And, popping in and coming out 7 minutes later with a pill that's going to resolve everything is really that's a bit of a wild concept. So this is the idea of being able to communicate with your clinician, or clinician to clinician, or behaviorist to clinician, behaviorist to owner. So you can start looking at what you're seeing and whether there can be a pain related component. Doesn't mean it definitely is, but it's definitely good to communicate, especially if you're like a behaviorist and you've seen posture change, you've seen some physical changes, you've seen some gait changes, and that really is all appearing to be tied up with a deleterious behavioral change. You can list them so that the clinician in charge of the case has a little bit of a hope of piecing the puzzle together. So when going back to the whole idea of trying to create that perfect chronic pain consult, not only to keep the client happy, informed, educated, that dog managed to the best of our abilities, the stress levels of the clinician as low as possible. These are some things that I use regularly. So I use informative diagrams. So in the consults that I hold, quite often I'll refer to some CAM diagram. I might quickly freehand draw it, or I might get it up on my iPad. I'm hoping to have all these laminated in a folder eventually, so I can just flick, old-fashioned flicking through laminated pictures. But as I say, diagrams can be really useful. So if you're a clinician listening, please do tap into the CAM resources and make use of these so that an owner can see it. I think I learn very much by seeing and reading. I don't take information verbally and hold on to it. I don't know what you're like, James. Are you really good at it?
I'm better at reading as well.
Yeah, definitely. And colour. So I have diagrams like this available so owners can understand about compensatory changes and how dog will transfer their weight away and how it can create other problems. And then we get these gaits that you just can't even put your finger on anymore. Where is the problem? Because the dog actually doesn't know where to put their weight anymore, because actually quite a lot of places are hurting.
Everything's hurting. Exactly.
Yeah. And then I don't want my owners to feel guilty. That's a really immediate reaction. If you've identified chronic pain, and the term chronic means that the dog's suffered for a while, the owner can become quite upset. They can become quite defensive. They can become a bit denial. And I always make sure I've got the ability on hand to explain how it's happened and to kind of take the weight of guilt away from them, because it's a subtle compensatory changes that aren't very overt. And I do find explaining it can be really helpful at keeping my owners on board, engaged, and not forgetting to listen for the rest of the consult because they feel so uncomfortable in themselves. This is the acute on chronic that James was talking about, trying to incorporate that into a consultation to manage expectations of how the disease is likely to progress. So these diagrams all do exist within CAM. If you want to get hold of them, get in touch and we can show you where resources are. But I also use lists because a lot of owners will come thinking that they're on a one-track pathway and there's no options left. And when you actually go, well, actually, we've got a lot to explore. And people go, oh, right, okay, let's get our game faces on. So having lists is very good. Also using flow diagrams. So these are classic CAM diagrams that I use every single day when I'm trying to get my owner onto a multimodal evidence-based management plan. So I go through this diagram. These are areas that often cause a lot of confusion and get neglected. This is one that Gwen has shared with me. I think it's from another resource, but I know that she's adapted it, and it gives owners an understanding that we start off here, and depending on how we respond, we've got this to go to, and depending how we respond, we've got this to go to. And it manages expectations. It gives them an understanding of the comprehensive nature of what's to come, that there are many choices to be made. I definitely find when I start offering people lists and flow diagrams, they buy into being more objective because they realize that there's many variables that we're playing with, and they're going to be the only people that are going to tell me whether my change, my adapted intervention is working or not. So I have found recently the list thing then supports the buy-in to being more objective. I use structure. This is another CAM diagram, again, to give people an understanding of who's doing what. I try and empower the owner at every opportunity that their input is greater than anything I could ever do as the clinician. I think I worked it out. If a vet saw a case for 15 minutes every 3 months throughout a year, they saw that case for 0.00023% of its life. And when you look at it like that, you go, yeah. The owner is the biggest player, and that's why the green pie pieces swamp the blue triangles. But again, it's just to show people that there's different interventions to be explored, and then breaking them down into who does what as well. This is a CAM expectation pyramid. Again, these are laminated. They're very easy to use. Not expectation. This is volume of influence pyramid. It's not a flow diagram. It doesn't mean you do this, it's the other. This is an empowerment diagram showing the owner that the volume of the pyramid is under their influence. They're going to identify and monitor. They're going to elicit weight control. They're going to change lifestyle, manage exercise plans. They're going to adapt the home. They're going to look into diets. They're going to take their dog to physiotherapy, complementary therapies. And it shows that I'm actually doing just a part, but the volume of influence is huge. And again, it's getting owners to realize that they can make dramatic changes. And regarding the home environment change, which James said is always difficult to incorporate into any consultation. It is so hard. You've been talking about hardcore drugs, and then you start talking about rugs, and they're like, I'm really sorry, I'm not with you on this one. So we have had this created. It's available for clinicians, therapists, anybody to use. Owners, go straight there. It's on the website. If you type in hashtag it's my home too, you'll find it through Google search. And it's a 17-question questionnaire trying to help owners understand how to make their home safer. It's adapted from a tool called the Home Safe tool that's used globally by occupational therapists and nurses. And it's huge amount of work that went creating the Home Fast tool. And we did our equal amount of work adapting it. We also have a lifestyle tool. Again, James said, trying to get people to understand about changing exercise, managing their home environment is really quite difficult. This little thing spins. Oh yeah, it spins. You can find this on CAM under CAM Interactive Lifestyle Tool, and it gives people guidance about hazards and how to improve them. So if you're struggling within your consultation, these are tools that you can send owners to. We talked about questionnaires and trying to get people to bring data with them. So this is available on the CAM website. You can email it to them. You can just give them the link. They can print it off and fill it in. And it's designed to extract information about lifestyle, about observations, about diets, about drugs that they've used before. And it just means that the owner is already thinking the way that you want them to think to get the best out of them. This is a report. James hasn't seen this, but I created this a couple of years ago because I was really struggling with the onion that we often have presented to us. We have layers of problems. We might have originally hip dysplasia that caused hip osteoarthritis, but we got secondary and primary obesity. And, those two conditions had ended up with us having back pain. And that's led to overworking of the forelimbs. And that's actually created a really grumpy dog. And the owner's absolutely at their wit's end, and they see this list of problems and they don't even know where to begin. Whereas I created this to try and get them to understand in what order things came and what our short, medium and long term and potentially lifetime plans were. And on the back of that diagram are the tools that we have to offer in what category, things that they need to change in the environment, activities they need to change, etc., etc. So that's another tool that's available that gives owner a really simple report sheet to go home with. I wanted to really remind people that it's not just about identifying the pain and prescribing drugs. Our role as clinicians, as advocates for that dog, is to educate, get the owners engaged, learn to empathize with them, because it really does buy you their support and trust. And we need to be empowering them to make these changes. So incorporating that kind of concept into your consultation is really important. Just because I'm running out of time, because I've got to go do a podcast in 5 minutes. These are some of the resources, guys. There's the Facebook website, Holly's Army. We've got Holly's Army, a brilliant place to send your clients, because we've got the CAM ambassadors that are really supporting people on a multimodal approach rather than the hit and run advice you see in some forums. We've got a product review group because consultations can get tied up with people saying, so tell me which bed to buy. So what raised bowl would you use? So what harness would you use? You can send them to there. We're on different platforms as well. Please don't forget the library of information. We've got a series that me and Gwen have done talking about the expectation pyramid. So if you're running out of time, say go to CAM YouTube and they're going to talk you through that diagram, each separate step. We do have a forum. We have a shop, and in that shop are these booklets. So again, every now and then we give them away for free. So if you're a client, like a tech or a veterinarian or a therapist, and you're like, really struggling, then there's a way that we might be able to help you with giving you a code to download booklets. We've also got that email series, and we've got our owner courses. This is a simple little dude. It's just a business card. Stock them. Have them in your practice. Have them in your therapist room. It's $4.99 for 100. All money goes back to supporting CAM, but it takes them to the resources. Just a big up about what we do. We do help also get the rest of your team singing the same way that you sing. So if you are a practice or a rehab centre and you really want to have that unifying training, we can offer you that. We do also do big owner workshops, so do get in touch if that appeals. This is for anybody that's thinking, God, I really want to bring this into my work. I'm a dog walker. I'm a pet shop owner. I run a dog kennels. We do have a course for you as well, so that you can make sure that you're offering the best advice possible. Don't forget our bandanas. They have a massive impact. We want practices to stock them. We want pet shops to stock them. They tell the world that there is a clinical reason for the way I'm walking, the way I am, the way I'm behaving, the way I am, etc. And it was a game changer when I had it with Holly. Think about looking into remote services. That was the flyer that I used when I used to run my remote service. I got so much out of it and I achieved so much. So do have a look around for them as well. There you go. Let me get rid of that and come back and chat to you. There. Sorry, bit of a list. But I think one of the things that I was like hoping to achieve with James tonight was to get the public to understand it's hard. There's a lot to cover.
Yeah, it's the tip of the iceberg, isn't it? The consultation is the tip of the iceberg. And I think having the CAM resources, things like that available that you can then dip into in your own time and, you know, do bit by bit is really helpful. You know, and you know, what we're trying to achieve is, yes, address the disease, address the pain and the discomfort, but then we want to start a new life for that dog or cat, really, in terms of we're going to build up your strength, we're going to build up your muscling, we're going to find activities that you can enjoy with your dog. So it's very easy to feel that, you know, once you've had a diagnosis, that's the end of something, but actually it can be a whole new part of your relationship and a really important, rewarding part as well. So
definitely. And I think I know that James is just kind of like beginning to start his journey with his own kind of remote service beginning to bloom. I'm starting a new part of my journey, and I won't lie, I'm ridiculously busy. I'm in first opinion practice. So if anybody is wanting to delve into this sector, I am actually actively recruiting. I am looking for veterinarians to come and join me. So if that fascinates you, then do get in touch. But I'm hoping tonight we've kind of given you some tools. I hope we've shown both sides of the table, what we are trying to achieve, and give us your commentary. You know, more ideas for sure. 100%. Now I'm gonna have to scoot because I'm supposed to be doing a podcast. I want to say a massive thank you to James. I love you.
Good to see you.
And we will see you again. Not you. We'll see the CAM followers. I think tomorrow night there's another live, but you will see James again soon. Yeah, so until then, thank you for listening. Please say thank you. Say thank you, James, because I love having him here. And we'll see you very soon. See you later.
Take care, everybody. Bye now. Bye.